Today, I just wanted to kind of go over, have folks present that have implemented intraoperative fluorescein angiography and have them talk about how they did it and what's working for them, so we can kind of get a little bit of guidance for those of us who haven't used it yet, and those of us who have used it get some tips. So Dr. Imai, if you want to come up and present, that would be great.
Dr. Imai, I have control of your presentation, so just let me know when you want to proceed.
Okay. So please start my slide. So if I want to change my slide, I should ask you, or can I do by myself?
Yeah, just let us know. Just let us know.
Okay. So today I present. So today I present how to set up the equipment for 3DFA in Kobe University. So next please. So first of all, to think about the setting, we all must know the principle of fluorescein angiography. The principle of fluorescein angiography is to irradiate tissue with excitation light through an excitation filter and observe fluorescence from the tissue through a barrier filter. Next, please. So for 3DFA, it is necessary to attach a barrier filter to the microscope and the excitation filter to the light source, as you know. Next, please. In actual surgery in Kobe University, I put both filters like this slide. I use photon from synergetic for the light source because it is easy to put the filter in. Next, please. Dr. Franklin told me that the older version of the Alcon constellation can also mount a filter in. If you are considering using this technique, I recommend checking the version of Constellation 1. In some cases, it may not be necessary to purchase an external light source. Next, please. In my first paper about 3DFA, I stated that we need to change the iris slider and gain setting. Next. However, I found that we can observe angiographic view without changing these settings. What we need and what is important is to change the color setting and to minimize the saturation. Next, please. I think to decrease the saturation is important for this technique. So I want to explain why it is effective to decrease the saturation. Before that, we should understand that each color has its own appearance based on three key attributes: hue, brightness, and saturation. So when you are describing a color, it is important to use all three of these attributes to accurately identify the color. So first, what is hue? Hue is defined as how most of us perceive and name a color using the colors of the rainbow, like red, blue, green, yellow, like that. So if we want to increase the visibility only by using the difference of hue, it is effective to arrange complementary colors side by side. Next, please. Next, brightness is a degree of a color's lightness and describes the luminous intensity of a color. And when the lightness goes down, the colors get darker and finally black. So if you want to increase the visibility only by the difference of brightness in the same hue, it is effective to arrange light and dark colors side by side. Next, please. Finally, saturation describes the vividness or dullness of color. The higher the brightness of the color, the closer it becomes to white when the saturation decreases. And the lower the brightness of the color, the closer it becomes to black when the saturation decreases. So even if the image already has enough difference of brightness and it is highly visible, the visibility can be improved by reducing the saturation and converting it to a grayscale image. Next, please. Conversely, in order to acquire a highly visible grayscale image, it is necessary to acquire an image with a big difference of brightness before that. For example, if you have an image that consists of light green and dark green is close to black, you can get white and black image by decreasing the saturation. In 3D FA, if you put a barrier filter in, you cannot observe any color other than green. So the background is black, which is the same as dark brightness green. Next, please. When the retinal blood vessels are visualized with fluorescence, the surgical image consists of two colors, the green of the blood vessels and the black background. So the surgical image already has a big difference of brightness and is highly visible. Next, please. However, by reducing the saturation of this image, the blood vessels are rendered white and the background remains black, resulting in an extremely easy to see grayscale image. Next, please. This is the first successful case of 3D FA I showed you in the previous meeting. This case was epiretinal membrane. As you can see, we are able to visualize the colloidal flash, arm retinal time, the warm staining of the vein, and the leakage from the microvessels. I hope you understand the reason why we can get such a highly visible grayscale image and the need for step-by-step color adjustment to obtain a highly visible grayscale image. Next, please.
Wow.
Next, please. Thank you. That's all.
Okay. Your videos are quality is just outstanding. It's I'll have to look and see what our saturation is, but it's some on our digital barrier. We do have a little bit of green coming through that I can out post-processing with Final Cut, but your surgical videos, just the detail and the contrast is incredible. So thank you. Does anybody have any questions? Nas?
Hello, everybody. So I missed a little bit of the ending of the presentation. The app just threw me out. What type of light are you using? Are you using a straight light, a wide field, a wide angle light? Is it because of your parameters that you could get a much broader area of defined grayscale, or is it because of the light source? Did you guys hear me?
Yeah, I heard you, Doctor. Dr. Imai.
I think he's muted.
Okay. Can you hear me?
Yes.
Can you hear me?
I can hear you.
Okay. So I usually use just a straight light. The reason why is by using the straight light, we can focus to the tissue where we want to observe. Okay. However, we can also use a chandelier light, and we can observe the wide field surgical view and do the perform like pan-retinal photocoagulation like that. I think to use the chandelier light is effective for that purpose. But if you want to observe more detail of the macula, to use the straight light is effective, I think. So we can use both. Okay.
I generally use both. I haven't done a lot, and I tend to elevate the power of the light as much as I can. But I've definitely have not gotten as bright images as you have presented today, which are pretty nice. And I will try it again to see if definitely I can get some images similarly to what you were presenting today. And as Alan was saying, we tend to have a little bit of a greenish hue with our parameters. I have used a grayscale parameter. I'm not sure if they're yours. I think they have, but I have not been able to get as defined grayscale as you have presented today. Vasculature is much more defined the way you've presented here than what we've seen in our OR. So pretty nice, and we'll keep in touch to see how we're doing with what you presented. Thank you.
Okay, thank you very much. So I have a question for you. What concentration of the dye are you using? I'm using the 1 vial for the staining. So what concentration?
I'm using, I believe it's 100 ml, and then we inject 2.5 mLs. Sometimes we'll do a supplemental injection. The first injection will look to see where the neovascularization is, and a second injection sometimes we'll put in when we're doing panretinal laser to look for ischemia, areas that are more ischemic in the periphery. That's what we've been doing.
Thank you.
So we do a 10% concentration.
Yes.
And we generally inject around 1.5 to 2 mLs when we're doing our cases.
So the concentration is the same. So I don't know why you cannot get
Do you manipulate the gain?
My gain setting is 1.
Oh, I think I missed that when I popped out.
My gain setting is 1. I never increase the gain because the image have a lot of noise.
Yeah, it tends to get granular.
Yeah.
Nas, a couple things that we've done that have helped, or we'll turn the light intensity most of the way up to 100%, or maybe just greater than 100%. That's helpful. And as Dr. Imai has mentioned, he'll open up the iris of the camera. Exactly. We haven't had to do that much. We've been able to keep the iris at 30 to 40%, but just increasing the light a lot. And we've tweaked the gain a little, maybe gone to 1.1, but much above 1.1 to 1.2, as we've all mentioned, it gets grainy. But we get a pretty good signal just cranking up the light.
I've done it, and it works. I mean, I get good images, but I find that Dr. Imai's videos are kind of, or more broadly defined in light than what we've been able to achieve. We do increase the aperture of the iris, and we have left it in 30 to 40% of aperture, and it works good too. I think we just need to keep on pushing buttons to see what we can find and make this thing better.
Yeah, and that's kind of exactly why I wanted to have a few people present and share their experience. So we'll have now, if everything's okay, we'll have Dr. Mishev present. Dr. Mishev's from Bulgaria, and if you follow him on LinkedIn, he does just some great surgical video, and he's really innovative and really smart with the science of light and the optics. So we'll have Dr. Mishev come up and present how he's gotten fluorescein working.
Can somebody unmute me?
Hold on, I'm queuing up his presentation. Give me a second.
Hi, I seem to be stuck here somewhere in the virtual reality. I want to thank to Alan for inviting me to speak in front of you about the intraoperative fluorescein angiography and thanks. And another aspect which is interesting, fluoroscopic vitrectomy with Ingenuity system. Can I have my next slide, please? So when I started to play with my attempts to achieve the fluorescein angiography, the first thing that comes to my mind was what type of endoillumination source I need to use in order to utilize maximally the wavelength that I need, which is basically around in between 475 nanometers and 495 nanometers. On the left side, you can see the spectral signature of the constellation. Then you can see the Goddard xenotron, in which surprisingly we might find even ultraviolet spectra around 380 nanometers, which is a bit dangerous. Then you can see the photon 2, where basically the 475, 495 is really low compared to the green and yellow range. And in the end of the slide on the right side, you can see the dark LED. So they at least have a good 490 nanometers light signature. So there is no doubt in my mind that the constellation spectral signature is the most consistent one, and this is my way to go. Next slide, please. I played a lot with different excitation filters because you might be surprised that they have a bandwidth, they have a peak of wavelength, and they have a level of transparency. So here on the picture are 5 of my attempts, which are from Semrock, Carecrest, Leica, Omega, and all reputable brands. So in reality, it's a trial and error process until you find your best approach. But still, I want to say that if you have not good excitation filter, you might compromise the level of your light, and also you might compromise the type of your fluorescence, hence the image that you're gonna get. Next slide, please. Here is a few of my modifications. Luckily, I have 2 constellation systems which are old enough to have the filter trace, and with a little bit of machine metal working, you can adapt excitation filter and to use the existing constellation light source as a source for your excitation. On the right side, I have a modified slider for a Photon 2, but my results with the Photon 2 were not so great compared to what I get with the constellation. Next slide, please. Barrier filter. I don't think that with the Ingenuity system we need a barrier filter. Why? Because the Ingenuity system is cleverly made to be able to play with the almost all the properties of the colors in real time, and you can make sort of a digital barrier filter recipe and to achieve the perfect image or a good enough image without sacrificing a visual information by putting a barrier filter. Because when you put a barrier filter, you, as the previous speaker said, you only let through the green light and you lose all the rest of the spectrum as visual information. The beauty of the Ingenuity is that you might extract from the image more than meets the eye. Next slide, please. So this should be the first video, I guess. It is vice versa. Okay. Now, we rarely speak about that, but when you use a really small amount of fluorescein in the eye and you switch to fluoroscopic view, you might be surprised how much vitreous in the periphery is left. You can play with different digital filter settings in order to extract more information, especially the underlying tissues, to be on the safe side, to know where you are actually, because the vitreous is well stained with the fluorescein and obviously is quite well visible here. So you can appreciate how much vitreous is in the periphery, and if you switch to classic view, you might miss that. So the basics of vitrectomy is actually to remove the vitreous, and at least me, I was surprised that albeit a meticulous cleaning, I thought that I'm a meticulous, I have vitreous in the periphery. So how can we clean something that we cannot see? So here comes the fluoroscopic vitrectomy. So can I have the next video, please? Another example of combined illumination. I have a chandelier with standard light. And can we press play, please? Perfect. And I have also the excitation light, or the fluoroscopic view. You might appreciate the vitreous, and later on you might see the subretinal fluid going out from this huge break. What I mean to say is that we are trying to make the machines to anticipate or to change the sound of the voice, of the sound of the machine, if we are in water or if we are in the vitreous, in order to know how to continue with our pedal. Why we need to do that? Since we can see the vitreous. Where is the vitreous? And the only way to see it actually is with fluoroscopic visualization. Otherwise, it is absolutely transparent. Now you can appreciate the subretinal fluid going out from here. So this is another application of the fluoroscopic capabilities of Constellation connected with Ingenuity. Next video, please. Yeah. I think I need to have at least 4 videos or more.
Yeah, absolutely. Let me just switch from the presentation to the videos that I have uploaded. Okay, 1 second.
Yeah, I think he had 2 MOV files and the rest were MP4s.
Yeah, so I have video. Yeah, video 1. Have we just played video 1, 2, 3, 4, or?
You just played it from not from the beginning and from the end, at least how I was putting them in the presentation.
Yes, so I guess let's start with video 1.
Okay, yeah, there we go.
Okay, this is a video on fluoroscopic angiography, or I must say it is angioscopy, and you can see the arterial phase. Later on you can see that there is a mild macular edema with a leakage. Yeah. So this is achieved with Constellation light source and digital filtering from the Ingenuity. Again, I emphasize that no barrier filter was needed to achieve this image in my settings. So this is the image here.
And what's your light source filter wavelength?
It's a 490 nanometers with 30 nanometers bandwidth.
Is that the IDEX one or is that another?
No, I'm not sure, but probably it's a Samrock bright line.
Okay.
Here is the periphery with indentation. We might see the periphery. Here we have a retinal detachment, limited detachment around the optic nerve, and the differential diagnosis here might be exudative one, but there is no leakage inside or collection of something as exudate. So you can even see a break here near to the vessel. So my take is that this retinal detachment was due to abrupt PVD. Still, it doesn't explain the leakage in the macula, so it was an interesting case. Yeah, you can see the leakage in the macula. Okay, next video, please.
That's a good dog, Teddy.
This one should be advanced proliferative diabetic retinal disease, and you can see the capillary dropouts and even the absence of, oh no, this is not this is actually a retinal detachment under PFCL, sorry, and this is a 360 degrees retinotomy, and you just might see that changing the color filters can change the detail perceptions. Anyways, probably we are used to more to the black and white image, and I find it with more contrast and detail separation here. This is the periphery where with indentation you can see this is the cut edges of the retina, so we have a bleeding, hence fluorescence. And the eye is filled with PFCL here. In my opinion, the most important thing is the light source in the fluorescein angiography. Next video, please. Now here, this should be the advanced proliferative diabetic retinal disease. This is immediately after the removal of the proliferative membrane over the optic nerve. And here you can see the choroidal filling, and you can see how much capillaries are gone, vanished. So this eye is more or less on the end stage of diabetic suffering, but still we can see how much the damage is, and we can of course guide our decision for PRP and the amount of PRP, and also to say on the next day of the patient why he sees or he doesn't see, where is the problem. Next video, please. Sorry, wait a second. Here we have the filters. Here are I have at least 3 or 4 types of digital filters. Again, I think the black and white one is the best suited for our needs. Here, probably I will magnify a bit more. Yes, so you can see perfectly well the remnant capillaries here. Okay, the next video, please. Now, this is a case, it was a hemophthalmos, and here there will be intraoperative endodiathermy guided by the fluorescein angio, because that way we can really see from where the leakage is. Here I'm examining the periphery, as expected, ischemia, and now what is interesting here is that we have a bleeding, but this is a pre-collected blood, not a bleeding vessel, otherwise it would be fluorescent. So it is on 6 o'clock, so it's just a blood collection. It's, at least for me, it's important to stop the bleeding intraoperatively, otherwise on the next day we know that we will have hemophthalmos. And yeah, here I have a leaking point which is clearly visible, and with endodiathermy I can close this leaking point. So another useful application for the intraoperative fluorescein imaging. Another one, and another one. Okay, can I have my next video? Now, you can see that on the right screen there are two sort of embols, or what is this, and we immediately did the angio and we saw that there is a perfusion on the vessel, so probably these are arteriosclerotic plaques, but there is no occlusion. Next video, please. Here during the surgery we saw that there is a hemorrhage around the optic nerve, and we were like, okay, what is happening? Is it a hemorrhagic or ischemic incident around the nerve? And we immediately did fluorescein angiography, and luckily this time it seems that it was blood related to the fluctuations of the IOP during the surgical procedure, and nothing special. At least the vessels show normal fluorescence at the moment. Even arteriovenous phase, double sign layer, it's a double wall layer, etc. So in that case we were lucky. But the fluorescein angioscopy was the intraoperative diagnostic tool to determine that. You can again appreciate the image quality actually. Here are the capillaries in the macula. Okay, can I have the next video please? Now this one was really interesting because during the surgery we noticed that the optic nerve is somehow pale, and this is the beauty of the ingenuity, that even the surgeon, to be focused on a certain particular step during the surgery, the surrounding staff can point things that the surgeon can miss. And this is exactly what happened here. One of my colleagues said something is wrong with the optic nerve. Then we performed angio, and we saw abnormal fluorescence around the optic nerve. Then when we waited a bit more, you will see that there is a lack of choroidal filling in the papillomacular area. So we assumed that it might be an ongoing anterior ischemic optic nerve neuropathy. Now, do you see the gray area here? Yeah. We might argue if that is the case or not, but what we did was that we immediately introduced fraxiparin and RTPA intravenously, and you will see by the end of the surgery that the area of the lack of perfusion diminished. I don't know if it was our efforts or it was a pure coincidence, but on the next day this eye was with 0.6 function. So we might assume that the fluorescein angiography was the one to help to save the eye, or we were extremely lucky and there was nothing there. Still, here you can appreciate the defect. And I think this is the last video that I have. Yeah.
That's right.
So, thank you very much for the attention.
Lukan, these are outstanding, and I think a couple of things. I mean, this is such a new technique that we're finding new information out, and I think new important information out as we go along. The choroidal filling defect, that's just fascinating. We've seen the little hot spots also with our diabetics, and I don't know if this is your experience, is oftentimes when we see these little hot spot leaks, if we flip back to regular visualization, we don't see any bleeding, even if we take the pressure down.
Yeah, absolutely agree with you. Absolutely agree with you. Yeah.
And I'm hopeful this is one thing that we might look into is those of us who are treating those if we have a lower incidence of postoperative hemorrhage.
It's absolutely new field of development of the visualization, and it's the perfect way to bring the pre-operative diagnostic efforts to intraoperative ones, because they are actually the reality of the eye. And we need to emphasize on that modality, and it is perfectly doable with the existing technology. I don't know what Alcon will do in the future, but the existing technology is perfectly suited for that.
Does anybody have any questions? Nas?
So I totally agree that grayscaling the images will definitely give you a lot more contrast on vascular tissue and depth perception. Very good that Lukan brought up the how can we evidence vascular leakage with intraop FA. I've found that it's more evident when we're not using any filter, because leakage will just come out greenish. So it's more evident when we are just looking through no filtering. For at least my perception is that it's more easily spotted just with the regular end-of-light filtering, where everything is blue and all the dye is coming out green. So maybe for this step, it could be a little bit more efficient, just taking the filters out. But definitely to see abnormal vessels, it's better with the grayscale and intraretinal leakage. It's best seen in grayscale too.
Nas, just a comment. The real bleeding at the moment will be with fluorescein, so it will shine. If it's a blood collection already there, it will be without fluorescein. This is the advantage of the fluoroscopic view.
Yeah, I totally agree. I'm just saying that sometimes we have really small neo vessels that are leaking, and we've seen it, and you can see it evidently with the grayscale if you intentionally look for them. I'm just saying that sometimes they can be so small that because of the grayscale we could miss them, and having that shiny bright green sometimes could make them more evident. But I'm not saying that we can't see them like this. I totally agree with you. It's just that I find that that blue-green contrast could give you a little bit of leverage sometimes when the leakage is very small. But then again, you guys have done a lot more than me intraop FA. So
we're certainly all learning. The other thing that's really striking is this the staining of the vitreous with fluorescein. I think that's great. That's really amazing visualization. Lukan, how much fluorescein are you putting in the vitreous so that you can see it?
So at the beginning, when I started before the fluoroscopic view, I was using like half a milliliter of 0.1% concentration. You need to dilute the fluorescein. It's not because if you imagine that we are using on roughly 4 liters of blood, 2.5 to 5 milligrams, we end up with 0.2% concentration in the body. So intravitreally, I think that anything less than 0.1% is absolutely harmless. and I saw that in my 2 years of experience with it. But what happened when I found the fluoroscopic view, it's absolutely enough, no more than 0.2, 0.2.5 milliliters of fluorescein to be instilled directly intravitreally. You need to wait like half a minute for that. The fluorescein is highly soluble and attracted to the vitreous, especially in the periphery, because it's 90% water and 10% collagen. Still, the triamcinolone is better for PVD visualization, but in the periphery, absolute king is the fluorescein, because you can see the stroma of the vitreous and everything is absolutely stained. So 0.2, 0.3 ml with less than 0.1% concentration.
Okay, that's great. Thank you. Nasir,
So
did you have
I've done
something
a
else?
little bit of fluoroscopic vitrectomy, and I think I've put a little bit more than what Lukan is saying inside the vitreous cavity. And what I found is that at some point it kind of like replicates itself inside the eye, and I think that maybe that amount of fluorescein inside the vitreous cavity is more manageable, because what I found was that we kept on seeing fluorescein all over the vitreous cavity through the whole case.
Sure.
I think because of the amount of fluorescein that we injected. And I wanted to ask Lukan, since he's done for a while this fluoroscopic vitrectomies, have you played with staining epiretinal membranes, not idiopathic epiretinal membranes, but like fibrovascular tissue and whatever it's on top of the retina, like just to get a glimpse of it, of the real tissue, if we're taking it out or not? Do you use something else other than fluorescein? Do you not use fluorescein at all, and just do some digital filtering just to see them a little bit better? I think we talked in the past that changing color channels or changing white balances can alter how we see things, and can highlight, depending on the white balancing, it can highlight different tissues. Just with changing the white balances, and pretty interested in what you've seen.
So starting with the fluorescein, if you put too much, it actually takes forever to remove it from the eye. That is why
Yes.
my effort was to limit the quantity of the fluorescein in the eye, because later on when you do a laser, it might be a problem because it flashes. So this is to answer the first question. The amount of fluorescein, in my opinion, should be as minimal as possible, where the fluoroscopic vitrectomy comes handy. The next question for staining the membranes.
I'll stop you. Just quick question.
Yeah.
So do you just inject it and don't do anything else? You just wait half a minute, or do you move the eye or make a little bit of fluidics inside so it?
At the moment, in the moment when you instill the fluorescein, it starts to spread to the eye. You just wait, like count to 10. Then it's enough the flow that you're gonna generate with the vitrector in order to create turbulence, and fluorescein will go in the periphery. I don't like any shaking maneuvers on the eye, because I find that strange, even for the patient. So I don't do it. On the staining ability of the fluorescein, when I started with the fluorescein, I tried to stain anterior capsule, I tried to stain epiretinal membranes, I tried to stain everything in the eye, and the only thing that is usefully stained is the vitreous. For epiretinal membranes, I regularly use membran blue duo, or I use a digital filtering. I have developed an ILM enhancement filter, which is basically playing with the contrast of the tissues, utilizing the simultaneous contrast concept based on the complementary colors, and basically it highlights the borders of the tissues. So I think for the membranes you can even use autofluorescent properties of the membranes. I have developed such filter also in order to distinguish them from the underlying retina. So we have two options. One is dyes, the other one is ingenuity. And I think the second one is the way to go. It's not doable in every scenario, but still we need to develop that.
Well, I think we're just a little over time now, and just to be respectful of everybody's Saturday and all the different time zones, we'll kind of wrap up now. We'll have the next time we get together, we'll have Dr. Matanti start off. I apologize we didn't get to your content, which is beautiful, but we'll start off next time with that. I was thinking of having another one in maybe 6 to 8 weeks. Does that work for everybody?
Sounds good for me.
Okay. Well, I think this was great. The other thing is just via email, I'll communicate with everybody, just some thoughts about, I'll kind of summarize the meeting and some, thoughts of the advantages of this technique, and the more input we get from good minds, the better. So I'll certainly, we'll be in touch by email, and I'd like to thank everybody that presented. The presentations were spectacular today, as well as everybody that made time on Saturday. So thank you.
Thank you. Thank you.
Thank you too. Well, thank you very much, Alan, for the invitation, and see you guys on the next Retinovers meeting.
Thank you. Thank you.
What's going on, Nick?